So a big welcome to everybody from across the world who've come for this webinar and this premiere of our film Surgery in the SynDaver Canine. You're very welcome to the event. We'll be recording the event and putting it online over the weekend, so it'll be available for anyone who isn't in the same time zone and anyone who wants to watch it again. The event will be my introduction, the film showing, a presentation from Dr Galina Hayes, and a panel for the questions and answers, which will also involve representatives from SynDaver, the company that makes the SynDaver Canine model that's featured within the film. So do feel free to send your questions through. I'm sure you'll have some as the film shows and as Dr Hayes's presentation is made and as other questions are asked. But do feel free to ask anything you'd like of the panelists. The film Surgery in the SynDaver Canine is the first episode to be produced from the film series DVM Training the Animal Doctor. DVM, Doctor of Veterinary Medicine, is the title and the qualification in a number of countries for veterinary students as they graduate. And the film series itself will be following the trajectory of a veterinary degree from the preclinical disciplines such as anatomy and physiology and pharmacology to the clinical area with clinical skills training and surgery training before graduation. So by looking at the whole of the veterinary degree, by exploring the different disciplines, what we're going to do is be using case studies from across the world, many of which we've filmed already, where teachers have developed and implemented humane, innovative tools and approaches that have either been part of a humane tradition within a certain country or discipline in a culture, or are new tools, new products that have replaced harmful animal use within veterinary education. And by harmful animal use, I mean dissection of purpose-killed animals, animal experimentation, and other instrumental animal use. And in some countries, in some disciplines, in some individual university and college departments, harmful animal use continues as part of a conventional practice for knowledge and skills acquisition. But in an increasing number of departments all across the world, the humane innovations, the alternatives have already replaced that harmful animal use and have become the standard way of teaching. And what the film series aims to do is to provide case studies from across the world so that teachers and students, as well as developers of these tools, can share their experience of their development and implementation. So we're going to be featuring people from a great number of countries and looking at all the disciplines within a veterinary degree, many different types of alternative or teaching tool, from software and virtual laboratories and virtual reality to models, mannequins and simulators, body donation programs for ethically sourced animal cadavers, and clinical learning opportunities where students have the chance to work with animal patients in a veterinary teaching hospital, an independent clinic, or out in the community doing work with shelters, spay, neuter work, and so on, which gives a great opportunity for students to get hands-on skills whilst helping animal patients at the same time. And of course, that's something done under supervision, following on from the training using non-animal models. All of these together can be considered as alternatives to harmful animal use. Many are non-animal tools, but they also are the humane approaches of body donation programs and work with patients, which of course can provide a a healing context rather than a harming context. So the series will show that, and Surgery in the SynDaver Canine is the first episode to be produced from that series, and we'll be looking at that full episode today. And as you know, this is a case study of one particular tool, the SynDaver Canine. We decided to focus on that one tool because it has multiple functionalities where students can be gaining skills and practicing their skills, mastering those skills within clinical skills and a wide range of surgical skills areas. So the episode that you're about to see features interviews with teachers who've developed and use that tool, demonstrations of the anatomy and the different clinical skills and surgical functionality of the model, and then footage of a student lab from Cornell University, where 3 different labs were set up for the students to practice in different areas of abdominal surgery. So this episode features very much the advanced surgery aspect of a veterinary degree, but also touches on the other clinical skills and surgical skills that can be gained using the model, but is very much an episode that addresses knowledge and skills acquisition, has a pedagogical focus, which is generally the focus that InterNICHE, our organization, has, looking at teaching objectives, learning objectives, and identifying what are the knowledge and skills that need to be gained, what are the skill sets, and how can they be best met using one tool or a multiple of tools and approaches. So without any further ado, we will play the full episode now. And of course, this episode and its summary clip and many other shorter clips extracted from the film are also available on our website and a number of other platforms. I'll be detailing this after the Q&A. But for now, let us look at this episode, Surgery and the SynDaver Canine, and I hope you enjoy it. Thank you.
My name is Dr Galina Hayes. I'm an assistant professor at Cornell University. I work in the soft tissue surgery section, and my responsibilities include providing service to clients and animals coming to the hospital either on an elective or an emergency basis requiring soft tissue surgical procedures, as well as training the students, both the third and final year students, in the theory and practice of surgery. Veterinarians are expected to know and do a lot and have a grasp of a very wide range of skills, which in my opinion may not be entirely realistic to expect them to accomplish within 4 years. And certainly a veterinary surgeon in their surgical skills will cross multiple species. So a general or mixed practitioner will often be doing surgery on 4, 5, 6 different species. They need to know the anatomy of all of those different species, their different pathophysiology, healing characteristics. You use different instruments, and yet their exposure to hands-on surgical training may be limited to just a few weeks in their final year of their DVM training. And within those final weeks, there may not be that many opportunities for direct mentorship. People that are undertaking specialist training for surgery on humans will undertake first an internship, then a second internship, then a residency, and only after they're into their residency would they actually be considered basically competent to begin to perform surgery. Whereas, of course, in the veterinary world, we leave and are expected to be surgically competent at the end of just our basic DVM training. And while I don't expect that to change anytime soon, I think we can change the way we deliver that training through the DVM program to try and make sure that the skill set that our graduates are equipped with is a little bit closer to what they're expected to have.
Within the sophomore surgery course, the course that I coordinate, I have tried to focus on clinically important, practical concepts, techniques, knowledge. What are going to make a difference for my patient? For example, GI surgery, very, very commonly performed. Dogs eat rocks and toys and they plug up their guts and then they need to have surgery. If you don't do the surgery correctly, there is a good chance they're not going to survive because they're going to leak the contents of their bowel into their abdomen. And they're not going to survive that unless they have emergency surgery, and even then sometimes they don't survive it. I'll spend a lot of time talking to them about how do you properly assess the bowel to make sure that you've got healthy tissue that you're bringing together, and how do you suture it together correctly, because you can suture it together incorrectly. Spend a lot of time doing it, feel good, and have a failure.
I certainly was very aware in the early parts of my career of how much I would appreciate face-to-face mentorship, someone delivering and improving my hands-on surgical skills. And so kind of carried that thought forward into my teaching career and really began that process of developing that training from the perspective of how can we teach a hands-on skill, and how can we move a subject which is often traditionally taught through didactic lecture into more of a hands-on apprenticeship type environment. And so really the wonderful thing about the SynDaver is at least it's giving us an opportunity to begin to bridge that gap. Yeah.
I do believe that if you understand the tissue properties and the pathophysiology of the disease, and you have basic surgical skills and common sense, you can apply those basic skills that you learn from your courses and maybe a clinical SPAY to other procedures.
In my opinion, surgery is a very it's heavy on hand skills, yeah, and you can talk about it in a PowerPoint all you want, but nothing really replaces having someone stood across from you, adjusting how you're holding instruments, adjusting your body position, adjusting your tissue handling, and it's those skills that translate into patient benefit and patient safety. Esoteric knowledge of adrenal gland vasculature is not helpful if you can't make your way to the adrenal gland in an atraumatic manner.
So here at SynDaver, what we're looking for is to fulfill curriculum need. The University of Florida specifically saw the need for an alternative to cadaver surgery. It was not working. And live surgery, too, was something that they did not want to persist with. They had specific curriculum tasks, surgeries that they wanted the students to be able to do that we needed to fulfill in the model.
We set up an interview meeting with them. We drove down to Tampa one day. We pitched an idea to them about using their technologies that they had already developed and had been marketing and applying on the human side for dogs. From a practical perspective, the vascular anatomy, so how big is the vessel? Where is the vessel? Is it there or not? Does it connect to the right places? With the texture of the organs, are they stiff, too stiff? Are they too friable or too soft? Because all the different organs, the liver, for example, compared to the spleen, the liver is very soft. The spleen is a little bit more stiff. And at first they were kind of the same. And now we've spent a lot of time on them and they're beautiful. The liver is very, very close to the texture, the feel, the compressive abilities, qualities. It's vascularized. We have a little bit vascularized of a dog liver. We've got quite an impressive high-fidelity canine now.
Yeah, so nice.
The first time I saw these SynDavers, the first thing you want to do is touch them, feel them. What does it smell like? Why is it pulsing? Is there blood running through these organs? And those are all things that are exciting, and just the realm of possibilities seem endless. The advanced surgery course taught us a lot of abdominal procedures, and anything from a splenectomy to liver biopsies, okay, to an enterotomy, to a resection and anastomosis of the small intestines, cystotomy, which is an opening of the urinary bladder. All these are really common procedures that every small animal veterinarian can do and should do in small animal practice, and those are all procedures that we were able to do in this SynDaver, demonstrated them well. It gives you a sense of belonging to something that's going to revolutionize the way your profession is taught.
So the first thing that I'm proud of and like is the fact that it does have a very realistic airway. The tongue, as well as the internal aspects of the glottis and all, allows intubation. Also the face, I try to give it kind of kind eyes, and you feel a bit of empathy for the canine as you use it. Second, we do have the ability to put IV in both front legs in the cephalic vein. To that, we can also draw blood from those areas. We have jugular veins. It is modifiable, so it allows central line catheterization, but you can draw blood from both sides. It also is a pulse, and you can create anesthetic scenarios where the learning experience can be beyond just what's being done within the dog. In the real world, you've got to worry about their breathing, you've got to worry about their blood pressure, their heart rate, and the dog, because of our ability to have it kind of change through a tablet, we can alter heart rate. We can put them in ventricular tachycardia. We can modulate them. Going down to the surgical consideration, we do have a surgical, they'll call it the abdominal skin plate. It has in it a linea alba that is a central area that allows surgery. The muscle, skin, fat, and fascial layers are all present, so that as a surgeon, if you cut appropriately, it kind of guides you. And that's really what we were attempting to achieve here, is that as the surgeon goes into the abdomen, you want to have it guide you as to what needs to be done. Specifically, there are pathologies that we have developed into the dog so that as a good surgeon, you would do a thorough exploration of the abdomen and be able to discern what you're supposed to do. And this is kind of part of the training. Looking into the chest cavity, there is a heart, as well as you can see both lungs and the bifurcation of the trachea. Since this can be intubated and hooked to a respirator, the lungs will expand, and you can, of course, adjust that to enhance the scenario. So we've designed this so that you have repeatability. The organs that are interfaced are replaceable. So specifically, this right medial liver lobe, which is the first organ, it is vascularized so that it will bleed. It allows practicing biopsy on it. They basically can do several procedures, both punch biopsy, they can actually do a ligation biopsy on this, and you could do a partial lobectomy where you could remove that as well.
Conceptually, what we do is very simple. We start out with a live tissue study, so we'll actually get a sample of a tissue. We'll run it through a battery of tests that can be, mechanical, physical. They can be things like, puncture resistance, coefficient of friction, abrasion resistance, tensile modulus, stretching, pushing, pulling, and measuring the kind of loads you get in response. Trying to figure out whether a material is more like a piece of spaghetti that's wet or a stick. The range of things that happen in the body, bone versus mucus versus muscle. Then using a knowledge of material science, you can come up with candidate materials to try to mimic all of those things. And you might have 12 different properties that you're trying to mimic. And through a process of experimentation and designed experiments, you can come up with a material that would be considered a validated mimic for skeletal muscle, for example. So when you take that tissue mimic, when you stretch it, when you push it, when you pull it, when you puncture it, it will perform reasonably like the actual live tissue that you're trying to mimic. And once you've done that 100 times, you've got materials that you can build an entire body with. Everything, even something as simple as muscle, is built up kind of like an onion skin. There's various materials inside, all of which are salts, fibers, and water, but they vary depending on whether you're trying to mimic a tendon or a ligament, or the lubricious surface of the muscle versus the more rigid core. Other parts like livers and spleens and all those sorts of things, they might look like a blob on the outside, but on the inside you've got ductwork and you've got vasculature and things pumping through them and all that sort of stuff. So
certainly, I think one of the greatest strengths of SynDaver use is in its ability to provide a very high fidelity environment for the practice of abdominal surgery in dogs. For me, the intestine in the SynDaver is the closest to live animal dog intestine that I've been able to find. It has very similar layering, it holds suture in a very similar manner, it handles the same, you can perform the same procedures in it, you're working down within a cavity, it holds staples in the same way that live dog intestine would. It certainly much improves the frozen dog defrosted experience. We've really tried to focus on two target audiences, if you like. There's general practitioners and ER doctors. The first would be a small animal practitioner in a busy small animal practice environment who performs surgery on a fairly regular basis. Probably the highest risk procedures that surgeons in that setting perform are intestinal procedures, and there's an intentional emphasis on intestinal procedures for those reasons. So the students are assigned in pairs to a cadaver unit, and they each alternate performing different components of the procedure. They gown and glove, they drape in just as they would for a live animal. They have the same instruments set up and suction and lighting and table that they would have for a live patient. And then our focus during the lab is to teach them gentle tissue handling, efficiency in their use of instruments, how to maintain a flow of productivity through the procedure and not get bogged down in sort of unnecessary snarls, and safety, how to maintain a sterile field, how to manipulate tissue so they can maintain good visualization. And it's those core skills which they can then take on and apply to pretty much any other procedure that they try and do in the future, but which are impossible to teach in a didactic setting.
This leads us to the bladder. And of course, the bladder specifically has a few pathologies itself. There are, in this case, 3 stones that are palpable within it. This, again, guides the surgeon to perceive there to be a problem. There's stones there. He doesn't know how many, so he must open the bladder, remove the stones, but thoroughly pass a catheter, clearing it, and then passing it again. We will occasionally hide stones, and it is a way of testing whether they're thorough in their pursuits and whether they take the dog seriously.
You can either create and flip your blade upside down, and just like Galina, do the reverse stab incision up, and then extend with a pair of scissors. Or you can paint down with the blade until you're in the lumen, and then extend with scissors. But I think either of those are fair.
Ready.
Don't. When you guys are suturing the bladder, please ensure again you go serosa to mucosa, mucosa to serosa to ensure that you engage the submucosa. Use your needle here to grab the loop. Pull up, right? That's going to tension the previous sutures that you placed, and then pull it down. And as you pull it down, you're going to be able to put it in the position that you want the suture to lay. And then once you're there, try not to move the knot, and then it's another additional 5 throws here, so 3 total square knots. And I like the way you're flattening your hands. Rock your hand and your needle driver in your hand as you go. And so as you rock it, it's going to tighten each side now. Looking at this, right, the only area that I would say maybe you're a little wide on that bite would be right here, right? And so you'll always be able to push a hemostat through, but we can kind of gauge the degree of apposition, and it's pretty tough to get through. If you were nervous about that and you wanted to sleep better at night, a simple interrupted right there would be fine.
Going further in, we're going to go ahead and, in this case, if the abdominal plate was opened, we would exteriorize the intestine. And again, as a good surgeon, you are thorough in your exploration and will feel of the intestine and determine that there are certain irregularities here that you don't want to miss. So as you go further in, lo and behold, here's a foreign object. So it feels kind of like a dice. How would I deal with this particular thing? Well, you would do an enterotomy. So at this point, you would cut, remove that foreign material, sew it up. But there's another issue here too. There's a pathology, an area of irregularity perhaps damage that was done by the dice. So this would guide us to consider this area an area where I would do an anastomosis.
What is going to be the preservation of your blood supply? And this is the hardest portion to figure out, I think, with a resection and anastomosis. Twofold is where to cut and what blood supply to save. And so, again, if we're pretending that we need to remove all the sutures of the enterotomy, what arcades need to go and what arcades need to stay. We have great blood supply from this jejunal arcade to supply this from this end. So then in theory, if you want to save this, right, where would you place the ligatures? Because we want to also think that we're going to want to make our cut away from the mesenteric surface at an angle, right? Yeah. We don't want to make it this way because then the tip of the blood supply is going to be poor here. So the way that you do have your carmels placed is appropriate. You want to actually pretend like you're placing a suture almost at the base of the intestine and ligating so that it's not bleeding. And it actually is like a very prominent artery that'll spurt at you, and so they can be a pain. So I find trying to create an environment for success before you cut the intestine is important, because once you cut the intestine, you're trying to get it back together as soon as you can. So plan, have everything set, then cut the intestine.
The SynDaver is great. It's got these big, long segments of bowel. And you can do an enterotomy where you incise it and suture back together, and a resection and anastomosis where you actually cut out part of it and then suture it back together, and still have a ton of bowel left. So when we're done with those surgery labs for the advanced students, we take all that viscera out and we cut it into little pieces. And then we take that tissue and we bring it to the basic surgery course. And then we put high-definition videos there, and we show them, this is how you do a gastrotomy. Here's your segment of stomach tissue. Here's the layers. Here's how you do the suture pattern for those layers. So they have actually done it in a modular sort of fashion as a sophomore before they get to that SynDaver experience with the full dog.
So I think surgery is very much an iterative, cumulative acquisition of skills. And when you begin surgery, you don't know how to hold a pair of needle drivers and you don't know how to tie a knot. And it's very appropriate that you learn to do that on a silicone pad. And then the next challenge after that becomes how to adjust that suture tension appropriately to the tissue that it's being placed in. And then a silicone pad no longer works and you need something that simulates tissue. And then the next challenge after that becomes, how do I do those things while working down and inside with another piece of bowel, trying to flop on top of a piece of bowel I'm working on. And then to learn that skill set, you need an actual full dog. And then the final part of it becomes, how do I learn to do that with a patient that's breathing and moving and bleeding, where I feel the pressure of emotional responsibility to the patient and the owner to perform optimally. And for that, you then need a live patient. And so you go through this process of silicone pad to isolated piece of bowel to simulator unit to patient. You would never think that your entire surgical training could be accomplished on a silicone pad, but you would never begin with the live patient. For any skill set, there is a learning curve that exists. When you're low on that learning curve, you will have an error rate, and what is important is for that error rate not be transmitted to the patient. Learning in an environment, just in the same way that airline pilots learn in simulators, surgeons need that same opportunity. Pretty much anyone can become a surgeon eventually. It's not difficult, but you have to have the environment to learn, and you have to have the environment in which you can make errors, and you have to retain your love for that skill set through that process.
Going further back, you can appreciate the stomach and the omentum, which is draping all of the intestine. This is a female dog. It's also designed as a spay trainer. We do have the reproductive tract represented. It also has the suspensory ligaments, the broad ligament. It has the horns, ovary. You would have to approach the abdomen, go in and break down that suspensory ligament, ligate the ovarian vasculature, and then come down, break it down, and remove this as you would a common spay. One of the concerns we have as surgeons who might do an ovarian hysterectomy is a condition called a dropped pedicle. So in the process of doing this procedure, If you did not ligate properly or were distracted or you sneezed or some problem arose, you might happen to not close the vessels that feed the ovary properly. Upon losing that or dropping it into the abdomen, it'll bleed freely, and that is considered an emergency.
I think it's important to recognize that all surgeons, no matter how experienced and how proficient, will run into situations where either they've made an error or just the nature of the procedure that they're working on means that some untoward event begins to occur. Typically that would be active hemorrhage, it might be loss of control of a ligature, it might be an insecure knot, it might be inadvertently traumatizing crucial tissue, but those events are going to occur at some point, no matter who you are and how good you are. And it's important, in my opinion, that students experience that emotion for the first time in a setting where there is not a live patient at risk and where there is someone available to mentor them through how specifically to address that issue. And so that's a great opportunity to give them their first introduction to that emotion and how to handle it. And some students just, people are different individuals. Some students handle it very well. Some students need to do that multiple times before they can really feel comfortable. Maybe comfortable is the wrong word, but feel able to perform competently under stress.
My goal in these cases is to have them fail. It's fine and good if everything goes great and you're doing things well, but in the real world that doesn't happen. You do have issues, things do occur, you see things that you didn't expect, and complications can arise. I want to put those things that you fear, those things that you would not want to happen on a real live dog, have them occur on the model, so that it's not simply perfecting the perfect surgery, but dealing with a complicated one, dealing with something that doesn't go well, and being able to work through that anxiety. My hope would be that in the real world, when these veterinarians come out and actually have a complication or a difficulty, they will be able to think back and say, this is easy. I had it much worse when I was dealing with the model.
We're going to set up a clinical scenario where one of their pedicles, secondary to a spay that they've been doing, is now bleeding. The patient is starting to decompensate, their anesthesiologist is panicking in a certain way and kind of set up a high pressure situation for them to try and figure out where the bleeding is and to then stop that bleeding. And so we can set the heart rate or the strength of the beat as well, and this should turn it on, which will then pump water throughout, which is our blood. Because your blood or your heart rate has now come up to 160 beats per minute.
There must be something bleeding. Okay, I'm gonna check your. Oh, there it is.
And your patient's heart rate is 180 beats per minute.
And this stupid hemostat is not working.
We're up to 200 beats per minute.
Suction.
Oh yeah, suction please.
Okay.
Alright, I found it. She's gonna go into cardiopulmonary arrest. Alright, I got it.
Okay, bleeding is under control.
Okay, and our heart rate is coming back down slowly here. And once you're done, cut that and release the hemostat and see if it's bleeding.
Not bleeding. We saved this. We saved him.
And so I would say that was really good. You guys identified the major bleeding pedicle. The only thing that I would say, instead of going directly in with a hemostat, right, start with the balfours, right, get in, improve your visualization, right, so you can truly see what's going on.
We were looking for the source of bleeding, and we found it. It was our dropped pedicle on the left side, and we isolated the bleeding and got a chance to tie it off and check everything else as well once over. And yeah, dog is alive, or never was alive, but is fine.
How did you feel as the crisis developed?
I mean, yeah, I do feel like the machine really hyped it up. Made me think something was really dying. But yeah, it was well controlled really quickly, and we were able to visualize everything very quickly, so that was good.
I think really the SynDaver Lab accomplishes multiple facets or multiple goals. One is to try and remove students' natural fear of surgery. It's very hard to behave with good competency and calmness when you feel stressed or afraid. The second is to encourage an enthusiasm for the procedures and for surgery in general, and encourage them in the idea that your surgical training is an iterative process. You acquire a skill, you practice it, you discover that you need another skill, you go learn it, you practice that. You constantly improve, and that's a lifelong career commitment. And the third is to give them a basic skill set which will translate into any surgical procedure that they undertake.
So we have created a series of pathologies right here, and I'm going to go ahead and kind of show you each one. There is a condition where the reproductive tract will get infected in an intact older female dog. It's called pyometra. It is similar to a spay when you have to deal with that, but the friability of the tissue, the fact that there's infection, and the consideration that it's a lot more vascular makes it more of a challenge. Another thing that you really don't get to see that often, but when you do, it's quite a serious consideration, is a diaphragmatic hernia. The diaphragm, of course, is the layer of muscle that separates the thoracic cavity and the lungs from the abdomen. And in that regard, if there is a traumatic event, hit by car, there'll be a rent in that muscular layer that allows GI to get into the thoracic space. This is one of our newer pathologies that I've really always wanted to create. A GDV is gastric dilatation volvulus. What this means is that an animal, a dog specifically, will gulp air, usually by eating quickly, then that stomach becomes distended with that air, and then it goes outside and plays and bounces, causing that inflated stomach to twist. So it's very important that they get to the hospital very quickly, that that stomach is deflated and that twist is corrected. Again, this is the type of pathology that I want every student to become comfortable with, to experience, so that when they do see it in the real world, and they will, they already know what to do. They already know how to save that dog. And even those who are familiar with and have seen these before, this could allow you to hone your craft. So the same was done for the spleen. As we showed, the popular spleen now is the one with the cancerous pathology that would allow bleeding to occur at that time. And again, the vasculature here allows either this 4-point ligation, or you could go along the hilus here and ligate these vessels and remove this spleen before the animal bleeds to death. When developing this, we actually had it basically validated by several surgeons. One of my mentors, I won't mention his name, was doing the splenectomy, and because it was a model, and your initial consideration is not to take it seriously, he went ahead and simply did a single ligation, just one clip, tied it, cut the spleen, removed it. Of course, it fountained, literally blew blood all over his chest. He said, "It taught me a lesson." I said, "Well, when you taught me, I do 3 ligatures and I tie it, and I do a transfixion. You have to do it right. And if you don't truly ligate something properly, it will punish you. Of course, if it's your live patient, it's going to punish them."
And so we have a conference coming up where we're and allowing general practitioners the opportunity to come and perform some fairly basic abdominal procedures, so things that they're probably doing every day in practice, under the supervision of boarded surgeons. And the goal of the lab really is not to teach them a new procedure, but to adjust their current technique in a way to improve their efficiency, their tissue handling skills, their instrument flow, teach them all the 1001 tricks of a surgical procedure, which make it a 20-minute very smooth procedure rather than a 50-minute, oh my God, I can't believe I just had to do that procedure. Yeah.
So this actually is our military trauma dog. It's designed for first responders and military units to simulate basically gunshot wounds, or if you had an improvised explosive device, shrapnel and such, and it's designed to die. You have to save it. There are certain skill sets that we want those individuals to do that are not typically done in the regular practice. So with injuries within the lung, you can have contusions, you can have fluid accumulation within the lung. The fact we have these skin plates, you would then get to the proper space, you would make your incision, and then track a hemostat in with a tube and pop into the lung space. And if you look at the abdomen, it's pooling with blood. There's actually bleeding injuries. Here's a spleen. It has basically shrapnel wounds and it's hemorrhaging accordingly. So this spleen would have to be removed to save this dog's life. Pretty severe. As you can see, poor child is bleeding to death before us.
Well, the most difficult thing about getting something like the synthetic canine into practice is the cost. We have a number of ways we can do to help the universities and different places acquire them. It's an investment. It's definitely an investment. The argument that we make, and the argument that's 100% true, is that you get superior training. If you really want to be in the business of graduating students that are going to be able to practice and perform surgery, you're doing them a disservice if you don't invest in this sort of platform. Ethical considerations aside, do the right thing and just save yourself a whole bunch of time and money. It's a good idea. If you've got a good model, it doesn't make sense to not use it.
People have to realize there really isn't an alternative to fulfill what I'm looking to fulfill, which is a superior experience, repeatability, controlled pathology, scenario-based.
For me, performing that kind of surgical training on a live animal which is being used solely for the purposes of training and is then euthanized is unacceptable for a large number of reasons, not the least of which that I believe it inculcates in the beginning surgeon the idea that the patient is disposable. I would not be ever willing to participate in a lab like that.
The only use of live animals in the training of surgery at the University of Florida is in our small animal hospital, where we have board-certified surgeons who are doing clinical surgeries with our professional veterinary students, either assisting or watching. I am not a believer in terminal surgery. They don't do it in human surgical training, and it's my opinion that it's not something that we need to do in veterinary, and I've always felt that way.
Ethical training will allow people to go into this profession and have a clear conscience, but I think, too, they won't be any less trained. You can learn good medicine and be ethical at the same time. And I believe in the long run that will translate to being a better, more empathic doctor, too, because you won't carry that burden. When I graduated, I did have to experience a terminal surgery. In hindsight, I don't feel that really taught me anything that helped me in the future. In fact, I still carry that scar. But it all circles back to that core necessity on several fronts. One, to preserve our own emotional and ethical kind of compass, as well as to allow us to be better clinicians, to give our clients better service, better medicine. I love caring for animals. I see myself more as a pediatrician than a veterinarian. I see veterinary medicine and the practice of veterinary medicine more about preserving the bond. I feel a great weight of responsibility that the connection between that client and that patient, that's just pure love. And our ability as clinicians to preserve that well beyond where it used to be, because we live longer now, and preserving quality is really why I think the profession has expanded so much. People are appreciating this unconditional love that these companions give, and by that we're able to be part of that connection. So it is a bond, almost like the old family physician, and it is really it's a joy for me, actually.
Thank you for watching that. I hope you enjoyed it. Some of you might have seen it before. It's been shown at a number of different events, national and international conferences over the last year or so, with specific audiences. And today is the big public launch, the premiere. As you can see with the credits here, there's a lot of people who are involved in the production of this film and the coming production of the other episodes from our sponsors, who we're very grateful to, a number of different organizations from around the world. So thank you very much to them. of course, also the developers of these alternative tools and the teachers who are using them and often have co-developed them themselves, and everyone else who we have interviewed and whom you'll see in other episodes. So you can watch the film online. You can also watch later this premiere online. More information will be sent out about that soon. But I'd like to go straight on to welcome Dr. Galina Hayes from Cornell University College of Veterinary Medicine. I'll introduce her first, a short biography, and we look forward to what she's got to say about the tool and the surgical training process. So Dr. Hayes is Associate Professor at the College of Veterinary Medicine, Cornell University in the US. She works in the soft tissue surgery section and is an expert in the use of simulators for surgical skills acquisition. She has a PhD in epidemiology and a doctorate of veterinary science focused in pharmacokinetics. And she has broad experience in clinical research, epidemiology, and clinical trials. So welcome, Dr. Hayes, and we'll move the spotlight onto you now.
Well, thank you so much for inviting me to be here today. It was wonderful to see the film in its entirety. I found it really quite moving, actually, to watch it and just appreciate the huge amount of work that's gone into putting that together, and the participation of so many different people, really with the goal of just moving the needle forward on surgical skills training and simulated training, specifically in veterinary medicine. I've been very privileged for the last few years in working at an institution where we have been able to bring the SynDaver Canine into use across many areas of the small animal curriculum. At this point now, we use it for both basic spay training, so feline spay training, which is sort of the first surgical procedure that students are exposed to. We use it for more advanced kind of GP level abdominal surgical skills training for students in their final year as they're moving through their clinical rotations. And we also use it for first year resident training, really just as an introduction to abdominal procedures and use of staplers and so on. And we've really found that it's been very helpful in providing or enabling us to provide a consistent training experience that we can reliably generate for each student in a way that would probably be impossible on clinical cases. We obviously are not comfortable ethically really incorporating terminal surgery into our curriculum in the small animal section, really trying to leave that behind us. And the SynDaver Canine allows a kind of safe environment for one-on-one mentorship, where all those early surgical errors can be made, but not transmitted through to a live patient. So we have really enjoyed using it as teachers, and the feedback that we get from students has also been very strong and very positive. We also recently conducted a research study looking at the effect on patient outcomes before and after simulated training implementation, and found improved outcomes in the patient group as well, with shorter surgical times, but also less requirement for analgesic administration in the immediate post-operative period when students had trained on simulators prior to their first live procedure. And while you would intuitively expect that, it was certainly reassuring to see that kind of outcome. I would say in general, certainly since I finished my own training, I graduated from vet school back in 1998, that there's been a shift over the years in the role that veterinary teaching faculty take in the curriculum. Back when I was training, teaching faculty were to some extent the gatekeepers of information. And now with the explosion of internet and online resources and online textbooks, videos, that really no longer needs to be the case. Factual information is much more straightforward to come by. And instead, it's the kind of clinical reasoning, the hand skills, which are much harder to acquire in any kind of online or didactic setting. And the use of simulators really allows faculty the power to sort of step into that role of, which is very exciting, of being being able to transfer a lot of those hand skills, clinical reasoning skills, discussion of how that factual information should be taken and used in clinical decision-making in an individual patient. And simulators really provide a wonderful stage for that kind of training to occur. Across the board, I feel like simulators are just reaching more widespread use in many different arenas. We now have simulators for laparoscopic skills training here at Cornell, and even robotic surgical training. And as medical technology becomes more and more sophisticated and more advanced, you have to kind of navigate the technical skills required to use that technology. And obviously, it's preferable that you're not taking those early steps in a live patient setting. And so simulators really become more and more just part of our everyday training environment. So that's all I really have to say on that. I'm just looking in the questions here. I can see some questions are coming up about costs. For Nick, I don't know if you want to step in and say anything after that.
We're going to welcome the two representatives from SynDaver shortly. I think they can give us some ideas of costs. But I know one question will also be about replaceability of individual organs. So that might be something that you and SynDaver could also comment on. So thank you very much, Dr. Hayes, for that presentation. Great to hear your experience of using the SynDaver Canine, and also how you have observed the changes in veterinary teaching and learning, not only through simulators, but also looking at how information is shared, who are the gatekeepers, as you said, and what are the sort of critical thinking skills and other aspects within the clinical field where students are looking beyond just hand skills, crucial as they are. So thank you very much for that. And I'm now going to welcome our guests from SynDaver, the company who make the SynDaver Canine. So I believe we have Tom Ewing and Calisse Revilla from SynDaver. So a big welcome to you, and thank you very much for coming today.
Thanks for having us.
So we're going to have some questions asked by the audience already, and I have some notes in advance with some other questions that people have wanted answering. One question that has come up several times is a question of the cost. What is the cost of the SynDaver Canine? What are the options for that? What are the different models? And a little about the replaceability of organs. Could you answer? Could you speak to that? And we can also ask Dr. Hayes about how often she is replacing different organs within the labs as the students use them.
Yeah, so we can address her. One, I'd like to say again, thanks for a very nice job on the film documentary, and Dr. Hayes, thank you for your comments there, and the detailed descriptions and from your practical usage. I think that's very, very important. In regards to current cost and affordability of the model, as Dr. Sackley's iterated on the film, right, that we know that these are investments, right, in training and in your program. So right now, the SynDaver model, the basic SynDaver surgical trainer, from a cost perspective, is right around $31,000. So that's a big burden. Most of our customers, especially here locally or domestically in the U.S., receive some type of grant or funding, right, in their programs in terms of how they acquire these products. So that's kind of the ballpark price there. And then programs that are using the models, quite extensively, right, on regular lab sessions that you saw, similar to what was being done at Cornell and UF and some of the videos there. They'll typically go through, and order consumable organs, based on the procedures that they're focusing on in that particular lab. And then we'll provide those consumable organs on an as-needed basis for them. So we usually work right with our customers to design that program. What is it specifically that they're looking to accomplish with the model in their training program? And then we design support structures, right, to make sure that they have what they need for those particular sessions.
So they're very good, very personalized approach, as it were, with the individual universities who are customers who then implement the tools.
Yeah, because I think they all, there are certainly similarities in what the different programs are teaching, but there may be different focuses on a particular lab session. So on a fall lab session, they may be focused on bowel resections and doing anastomosis skills. And then on a different lab session, they may be focused on, right, a different procedure. So their needs will differ, varying during the time of the year or what function they're supporting.
Thank you. Dr. Hayes, would you like to speak to that in terms of how many models you have and how you work your way through the different organs over time? How many labs are there, for example, for students?
Yeah.
How much?
Yeah,
how
absolutely.
many of the organs are you using?
Yeah. So let me break that down. So for our general abdominal procedures lab, which teaches kind of GP level surgical skills, gastropexy, intestinal RNA, enterotomy, cystotomy, and how to manage a drop pedicle situation during a spay procedure, so acute hemorrhage type scenario. That is taught to all of our final year students. They all receive that lab at least once, some of them twice. It's taught in the students run with a 2-to-1 ratio on a SynDaver model. So there's 2 students working on each model. One acts as the primary surgeon, one as the assistant, and they switch roles for each procedure. So they each get to be primary surgeon for each procedure, and the other one assists. And we have no more than at the most 4, but the vast majority of the time 3 SynDaver models. So a total of 6 students running in a ratio with 1 faculty. Yeah. And we don't like to go much beyond that because we start to lose some of the sort of direct mentorship that the lab is ideally suited for. So we try and keep it on that 1 to 6 student ratio. And even within that 6, only 3 students are being primary surgeon at any one time. So you get the opportunity to watch and mentor quite closely. Now, in terms of organ consumption, we have the program, the teaching planned to optimize reusage of the organs to try and keep that expense down. And so we get on average 12 usages, sometimes a little bit more out of each organ set. And so that's a total of 12 incisions made. But we also have some of the procedures set in such a way that we're taking out suture and then having another student just replace suture rather than making the incision from scratch. So that gives us a little bit more. Yeah. The biggest outlay cost for us was the initial purchase of the SynDaver units. And then we now have teaching funds sort of dedicated to paying for organ replacement on a sort of annual budget. And we also get help from private donations from alumni and essentially benefactors to the university that agree with the importance of a surgical simulation program in veterinary surgical training. So that's sort of really how the main final year program began, and how we run that one. We also, a couple of years ago, added on a simulator lab for teaching the first spay procedure. And so just to back up slightly on the history of that, students would learn basic skills training on surgical pads, so knot ligation, suturing, things like that on just basic tissue pads. And then they would perform a live cat spay on spay animals recruited from local shelters. And so that's a lab where you have typically 10 students performing a spay at any one time, supervised generally by 3 faculty. But we felt that the jump from suture pads to live spay was too sharp. And so when SynDaver produced a feline dissection model, I think it was originally intended for the sort of high school market, we jumped all over that and had them add on a sort of adapted uterus and reproductive tract into that model, and then incorporated that model into skills training. So they perform a spay first on that feline simulator before doing a live spay. And it's slightly different in that this is done as sort of more of a mass lab. It happens once a year. We recruit faculty to help mentor that lab. But one of the big cost savings for us has been that it doesn't require anesthesia. You can schedule it much more readily. You don't have to the cost savings just in terms of then running the live lab that follows it are there because the surgical times are substantially shorter on the live lab. Now we have the simulator lab first. And so that then frees up faculty, frees up anesthesia, reduce anesthesia costs, and also improves the outcomes in those subsequent live animals. We find they need less pain, analgesic administration, less need for painkillers in the post-op period. And so we've really appreciated that. And SynDaver also worked with us to make sure that the reproductive tract that was incorporated into that feline high school model was appropriately fragile. And so that allows us to really emphasize gentle tissue handling and safe technique when we teach that program. So those are probably the 2 main areas. I'm bringing up the feline model just because my recollection is it is somewhat less expensive than the canine, and it has abdominal pods that can be reused, and we get many, many uses out of those pods. We just replace the reproductive tract between each student, and the reproductive tract is, as I recollect, really not very expensive.
Thank you. Tom and Calisse, or Calisse, can you answer, is that feline surgical model available publicly now?
It is, yes. We have it's called a copycat, and that one is $5,700 or so, and you get the chassis that you hang on to that's made of silicone. And then, as Dr. Hayes mentioned, the organs are syn tissue, so that more realistic type of material that comes in a replaceable organ sac that is about $1,100. And then you can get repeated uses out of that.
Excellent. And we have a question about the other animals that the animal models that you've produced. I know, could you tell us about the different surgical models or the different surgical versions for the dog, but also other species that there may be surgery options too, otherwise models for dissection that might be at tertiary level or might be secondary level?
Yeah. And I'll let Calisse chime in as well, because she always catches things that I miss. But from the canine aspect, right, we have the full SynDaver surgical trainer that you just saw documented in the film. Now that has gone through some revisions, right, since the time of the film is being made. Still retains all of the capabilities that you highlighted in your documentary, and that Dr. Hayes has referenced. But we've made some changes to make care and maintenance of the model significantly easier, in terms of just the materials that the model is made of, while retaining all of the same feel and capability of the abdominal organs that you represented earlier. The other version of that model is, instead of the full dog, it is just the abdominal chassis pod, right? So no legs and no head or airway. And that's actually what one of the other programs has just switched over to. That's a big user of the model, just because they don't interact with the extremities or the head so much in there. They just focus on the abdominal sector of the model, right? So it's all draped and they get the same effect, for their students. So there's an abdominal trainer. And then we've just come out and just released here in January a modular canine model. So looks substantially different than the model, right, that we just highlighted, in that it's, it appears, right, as a real canine would. And it's got 3 different variant structures or formulations, or if you will. One would be a vet tech oriented model, right, where we'll train more of tympanic membranes, right, urinary catheterization, splint placement, all those things. A trauma version, which is more geared towards law enforcement or government use, with traumatic injuries and things like that with it, and then still capable of all of the surgical aspects that we just highlighted in the film as well, right? So the theory and the thought behind that is programs could start off with one version or just components of it, and over time be able to build up into a full model and then expand that model's capabilities across a couple of different platforms. So that's available now that we've started working with. We have the copycat that Calisse just talked about, and Dr. Hayes is absolutely correct. It was originally designed as a high school dissection model, but with input from Dr. Hayes and the group at Cornell, adapted into a spay trainer model now for the feline, which we are now, based on the results of their latest study that she just talked about, are now offering that, right, as a spay training model. And we've done some refinement on that model, which will also enhance the external anatomy training and identification of musculature and other structures on the model. And we'll be refining, we're in the process of refining some of the internal organ components on there to bring it up to the level of the surgical canine, so that its uses, right, will be a little bit broader, beyond high school dissection and just spay. So that continues in development. We have an equine model that was developed with another partner here, veterinary school partnership here in the States. That product is still officially in prototype form, if you will, although we do have about 20 or 30 of them in use, across various different institutions, but we're still refining just how that model is constructed and put together. And we hope to be able to bring that back into full production at some time later this year. Beyond that, we're always looking for, what could be the next model. We have a prototype primate model that was developed for a customer. We're not sure if that's going to be, brought into, right, open production and available for everyone. And then, we've had requests for other, high school based dissection models and others. On that, we also have a synthetic frog, right? So a fully dissectable synthetic frog, mainly targeted at the high school market. again, getting away from using live frogs in those markets and the chemicals and associated ethical concerns that are present there.
I'm
So
sure
I think
lots
I
of people
covered
will be
everything.
interested in a rodent, a rat, and a mouse model as well. There'll probably be lots of options and interest for that.
Yes. That's one of the, I'll let Calisse chime in, but I know that's one of the, the areas that we've had requests for, as well as a dental training model for a canine dental model.
Okay.
The only other thing I was going to mention is we also offer airway trainers for the canine. So Tom mentioned we offer just the abdominal surgical trainer, but likewise, if you were just wanting to teach intubation, for instance, we do offer solely airway trainers in both the deluxe and basic version.
Thank you. There's a question about IV access and using a vein. How many times could a vein be punctured before you need to replace the tube?
It's a good question, and we get it a lot. And the straightforward answer is, it's multiple times. It all depends on the gauge of the needle being used. A lot of our customers are using, a drop of a drop of super glue afterwards to help seal things up, and then continuing to move the needle around. But in any, vascular access piece, those are typically a replaceable component, where you see those in the limbs, both fore and hind limbs. So we make those as consumable, but they're getting multiple sticks. I think we're getting in some cases a dozen or more sticks before, we can't seal them up anymore.
We recommend using a small gauge needle and then turning the pressure down on the pump, because you can actually control the pulse rate and flow on the tablet that we provide. So small gauge needle and turning the pressure down, and then you can get a good number of sticks out of each vessel.
Okay. In terms of the number of SynDavers in use at veterinary colleges and vet tech colleges across the world, what's the distribution in terms of numbers of SynDavers and the geographical range?
So we've got about 200 surgical models in the market today, across the globe, right? So both domestically here in the US and internationally. They're predominantly at 4-year DVM schools, although there's a wide adoption that has been started over the last couple of years at vet tech programs, 2-year veterinary technician programs adopting the model as well. So and that's also why on the modular K9 we had a veterinary tech specific configuration. So we think that's going to continue to expand. Our goal right now in the US, there's, I believe the number is up to almost 30 veterinary schools, 4-year veterinary schools, and currently we have a presence in 20 of them. Our goal is to be in every one. We do believe that it's the preeminent training model to bridge that gap, as Dr. Hayes pointed out, right from that building block procedural stage, learning the skills transfer before you get into live animal, and practice your skills there, or refine your skills. So we keep looking at that. We've had multiple demonstrations just so far this year at some of the remaining veterinary schools that are considering adopting this training platform in their programs.
We've shown the film in a number of countries as well, including translations of the film in Bosnia and Bulgaria, for example, and in both universities, both veterinary colleges, they're interested in a potential purchase. So they are or will be in touch with you about that, I believe. The issue of moving from work with the SynDaver into the clinic and working with animal patients. Dr. Hayes, how do you help guarantee the skill sets really have been met by the students? There really is the confidence and the competence before students are working with animal patients. And how does the sort of supervision element of work with patients work?
Yeah, well, certainly on the surgical rotations and all the rotations in which the students are performing surgery. So we have a shelter med rotation and a primary care surgery rotation as well. Students are very closely supervised, and there's direct one-on-one supervision through all of the procedures that they perform. That's both for the patient's benefit, but obviously also for the student's benefit. It's a scary thing to do surgery for the first time or the first time on a live patient. You know, in terms of guarantee, I don't think there really are any guarantees in surgery, unfortunately. But we do the best job that we can, and I think incorporating simulators has helped us with that. And I'm hopeful that the simulation field will continue to expand. I mean, I think SynDaver have done a great job, but as they say, they're pretty much the only high fidelity unit on the veterinary market right now. And I hope that over the coming years, you know, no offense to SynDaver, but that we will see other players coming in. I think we all benefit by having a sort of diverse array of units available that fit multiple applications and multiple price tags. It's not an easy field to market to or to get into, and it's kind of new to veterinary surgery as well. And so, you know, it takes a little bit to look at a unit and then figure out exactly how you're going to incorporate it, and then sort of sell that concept to administration and get everyone on board and moving in the same direction. That's not always super easy to do. But yeah, it's been very rewarding for us over the last few years, that's for sure.
And with the simulators such as this and a range of different non-animal models before students work with animal patients, I presume there's no risk of a university or a college losing their accreditation. Would you find that involving these high fidelity simulators is something that supports accreditation for universities that are going through an assessment or haven't been accredited before?
Yeah, I mean, I don't think that's even a concern that there would be a loss of accreditation. I think incorporating simulators like this speaks to the university's dedication to providing skills training in a ethically responsible but also consistent manner in a repeatable environment that allows for structured assessment. And all of those things are, you know, kind of buzzwords that are key to people who are assessing the training experience. So no, I don't think there would be any concern about moving away from a live animal kill lab to a surgical simulator lab in terms of achieving accreditation. Yeah, definitely not. And in fact, you know, I think conversely, more and more, and maybe appropriately so, students are voicing their preference for artificial simulators. And wanting to have more of a say in how their training is conducted. And I think probably the time is coming in the not too far distant where it's going to be quite difficult to get students to agree to participate in a live kill lab, and maybe that's you know, appropriate.
And I guess those labs also teach some negative attitudes and perhaps don't teach the other skills so well. What's your opinion about the broader range of teaching objectives that can be met in different ways, the extra objectives that might be met using a simulation lab, and the negative lessons that harming or killing an animal in training might also impart to a student?
Yeah, I mean, I think Dr. Danielson spoke to it in the film when he said that he looks back on his live kill labs and really doesn't feel good about that experience. And I think that's certainly a sentiment that I've heard before. I came from a UK training background, and just speaking personally, we did not, certainly when I was training, have any live kill labs in the UK. And the veterinary oath in the UK is to allow no animal under your care to come to harm. And for me, teaching a live kill procedure would contravene that oath. And so for that reason alone, as any others, I wouldn't be willing to be part of that. It's not something that I've ever done. Having said that, I certainly have colleagues and friends who, maybe they began teaching 20 years ago. This was the sort of established way it was done at the time. I certainly don't want to derogate or lessen the effort, and a lot of these people are dedicated teachers. And I think they've done their best. I don't want to say anything negative about that, but I also feel like we're fortunate in that we're moving into a different era where we have the technical skills capacity to produce something that really comes pretty close to replicating a live surgical experience, and has a lot of advantages that we've talked about here and in the film. I would hope that this is the future.
Thank you. And I guess really the point is not to be doing an animal experiment, as some people might think is necessary. A few remaining people might think this is necessary in a surgery lab, but really is to focus on the skills acquisition, how to master those.
Yeah, and I think for me, surgical skills can always be taught. Yeah. What can't be taught is attitude, or dedication, compassion for your patient. And I don't think a live kill lab really encourages any of those things.
What are the studies that address the use of the SynDaver Canine or address the use of simulators for surgical training? Have there been a new range of studies coming out about the use of the canine, and how many of those are sort of comparative studies?
So there's a solid growing bank of literature on surgical simulation. The Journal of Veterinary Medical Education is probably the best venue for that. And there's been some variation in findings. I think in general, and hopefully I'm not misquoting here, but in general, we're seeing an improvement in surgical times when surgical simulators are used first. Almost across the board, there's an improvement in student confidence as they're going into live procedures if they've been simulator trained prior. And probably a growing area is looking at influence on subsequent patient outcomes. And I think I talked about that a little bit in answer to one of the earlier questions.
Yeah. I think in general, right, Nick, you can look at simulation as it's progressed, right? I come from an aviation background. So simulation has been an integral part of, my training and skill development and progression through aviation. And I couldn't imagine, right, doing some of the things I've done in an airplane and carrier-based operation without having simulators and simulated those events. I think the healthcare industry over the prior years has been moving and adopting simulation, first on the human side, quite extensively. And now you've got, as Dr. Hayes pointed out, right, there's a plethora, right, of products and different, platforms available on the human side. There hasn't been as much focus on the veterinary side, but I see that continuing, right, after attending some of the trade shows. And I think things that she pointed out that you're seeing with simulation is skill development, skill progression, and refinement, confidence in, right, the student and in the learner in being able to do and perform a procedure or a technique. And then you see the benefits in postgraduate, in this case, learning, where it's skill refinement, I think, as Dr. Hayes talked about in part of the video, and then skill retention, right? If you're not using a skill or haven't done a certain procedure in a time, your proficiency level starts to degrade. And simulators are a great way to go back and refine, especially those physical hands-on movements, right, that you need to retain to be proficient, right, which translates into better outcomes, less patient pain or discomfort and those types of things. And I think the veterinary healthcare market, veterinary medicine, over the last few years, with the help of programs like Cornell and others, has really started to pick up on the adoption of simulation and its value and its benefit, right, in terms of, overall, again, instruction and patient outcomes. And I think we'll continue to see that. We are already seeing students, as you referenced, in the human anatomy side and human surgical training. A lot of our customers use the SynDaver models as a way to entice, right, their student and get registered, right, and keep their student populations up. We've made this investment in technology for you. You want to come to our program. And I think we'll start to see and are starting to see that on the veterinary side as well.
Thank you. Calisse, did you want to add anything before we come to the end of the panel?
I was just going to say, even as young as middle school and high school, where we have students using our SynFrog for dissections, we are seeing a higher number of attendance rates when they use synthetic frogs versus a lot of students and or parents choose to opt out if they're using deceased frogs. So I think that can relay to higher education as well, with more students being willing to participate. And then especially on the human side, a lot of chemicals and formaldehyde, for instance, are used. So that excludes pregnant individuals. There's no biohazard, no harmful chemical exposure with the SynDaver. So that could provide opportunities to those who might otherwise not be able to participate.
So yeah, a better learning environment in many, many areas, and also more inclusive, which I think is really important. Dr. Hayes, any final comments from you before we close the panel?
No, not really. I guess just the traditional paradigm in surgery has been see one, do one, teach one. And I think now we're moving to see one, do one on a simulator, do one on a live patient, and then teach one. And I think that's a good thing.
Excellent. Okay, well, thank you very much indeed for the panel. I'm going to have a few minutes just to conclude the webinar. But thank you very much to Dr. Hayes, Tom and Calisse for participating, Dr. Hayes for your presentation, everyone for their contribution in the questions and answers. This webinar, as I mentioned, has been recorded. This will be made available over the weekend, and the wider launch with news release will happen on Monday, the 4th of March, 2024. So keep an eye out for that. If you visit our website at interniche.org, you'll see all the content of this episode, Surgery in the SynDaver Canine. That's the full episode, a summary clip of half length, 10 thematic focus clips, for example, looking at the concept of skills acquisition or the different types of simulators and tools that can be used over a veterinary surgery training. And then over 100 short excerpts. And these focus clips and short excerpts are all derived from the episode, but are very useful for any user who wants to use them within a training course, within their presentation or PowerPoint. So we've also got a lot of translations. A number are already online and more are being added by the day. So this everything from French and Spanish to Arabic, traditional Chinese, simplified Chinese, Korean, and so on. So a lot of different options available there for users from across the world and to use the film for different purposes. So the video itself can be used to demonstrate this specific tool, to guide people into what are the key issues with skills acquisition and how to ensure it, to support the replacement of any remaining animal experimentation, including terminal surgeries, where it might still be in use in some surgery departments, and to support the enhancement of veterinary training, because well-designed tools, I believe, can reflect a greater sensitivity to the learning process. The next episodes that will be produced will be coming over the coming months, covering the other disciplines in a veterinary degree, the range of other humane methods that are already implemented in many departments across the world, and various individual products. And we have content for those episodes from all across Mexico, Peru, Colombia, Brazil, Portugal, the UK, Norway, Denmark and Germany, Ukraine and Russia, Bosnia and Serbia, Egypt and Kenya, India, China, South Korea and Japan, as well as more footage from the US and Canada, both small animal and large animal, and a number of different species. So news and information about these next episodes or sections of them will be made available on our website. And as a final conclusion, thank you very much again to Dr. Galina Hayes, to Tom and Calisse from SynDaver, to our tech expert, Ellen, and of course, everyone who's participated in the production of these tools, the implementation of these tools, the study of these tools, and those who've helped sponsor this film, the film series, and our broader work. So thank you for watching, thank you for listening in, and thank you for participating in the ongoing process of changes in the curriculum that are bringing benefits to students, to teachers, to the professions, to society, and of course, to the animals as well. So thank you very much.